Thanks.
Right. And Anna, can people see me or only the my PowerPoint?
They can see you and the PowerPoint.
Okay, I'll try to look extra professional here.
Aaron, so we have 9 folks that are signed in.
Great.
So whenever you want to get started.
Okay, I will get started. I believe I had 9 people in my 3rd grade class, so that's a good quorum. With me, that makes 10. That's a full minion, and we can start this conversation right now. Welcome to one of the monthly webinars from the Maryland Addiction Consultation Service. Since you're signed up for this webinar, you're already aware, I'm sure, that Maryland Addiction Consultation Service, let me make my PowerPoint advance here, provides support to prescribers and their practices in addressing the needs of patients with substance use disorders and chronic pain, particularly chronic pain that has been treated or is being treated with opioids. Funded by the state, free to you, and we have both individual consultation resources as well as technical assistance to practices implementing or troubleshooting their substance use disorder treatment services. We can provide assistance with addiction, behavioral health resources, and referrals. And I have now a project as well, which is off to a great start, hosting an ECHO clinic, which is collaborative, basically a periodic collaborative video conference with providers from around the state, collaborating in conversation with experts. So really great set of resources, and I'm proud to be one of the consultants with the Maryland Addiction Consultation Service. As you probably know, because you signed up for this talk, this will be a discussion of toxicology testing in addiction treatment, particularly with a 2020 flavor, but the most timely information will kind of be in the examples towards the end, so we could talk about that a little bit as well. But I'm going to spend the first part of this talk discussing some of the background, some of the basic concepts of toxicology testing, and then we can talk about, my hope is that you'll emerge from this with a more nuanced understanding of the tools that you're probably already using to evaluate your patient's diagnosis, treatment, and progress for their substance use disorder treatment. I am a family doctor. Oh, by the way, if you can see me, I am currently sitting in my basement, like many of you. All I'm balancing work and extra childcare responsibilities that have resulted from this pandemic. And so if it looks like there's a water heater and some pipes behind me, it's because there are. I think this is the only part of my house that my children are not going to be able to find me during the talk. But if they run in, I'll tell them to leave. So I am a family physician. and an addiction medicine specialist. And I'm currently serving as in addition to being a Max consultant, I'm the medical director of the addiction treatment programs at 1001 West Pratt, which includes an opioid treatment program, an office-based program, where people primarily get prescriptions for buprenorphine sublingual treatment, in addition to the injectable buprenorphine treatment currently available. We have, in normal circumstances, we have an intensive outpatient program. We have a deaf addictions program. We have a hub project that helps get people who are challenging to stabilize on Suboxone. We could get them stabilized in a more structured setting before transferring them back to their community provider for continued buprenorphine treatment. We have integrated primary care and infectious disease treatment. And I'm also a preceptor in the University of Maryland Family Medicine Residency Program. I mention these roles not to toot my own horn, but just to give a sense of where I'm coming from when I'm thinking about toxicology testing, and probably also expose some of my blind spots or weaknesses as well. So I'm not a psychiatrist. I'm not a pain management expert, although I do treat a lot of patients that live with chronic pain. And so I apologize for any omissions that I make here. I take responsibility for them, and please bring any clinical issues that I think I've left dangling out there up in the comments section, or which I can hopefully address during the talk or after the talk. So outline of the talk, I'm going to talk a little bit about why we get toxicology testing. I'm going to review the key vocabulary, which has some tricks to it. I'm going to talk about the common clinical test matrices and characteristics. Matrices is the word we use to talk about what we're testing: urine, saliva, blood, hair and nails, sweat or breath. And I want to talk about some of the peculiarities of individual substances that we test for as well. If I talk fast enough, we'll have an opportunity to discuss cases at the end, which will give us a chance to just kind of think through some interesting cases and figure out how to respond. And hopefully I'll have some time for questions either during the talk or after the talk. If there's burning issues that come up, please feel free to enter into the chat. I actually just saw a chat kind of materialize on my screen, so I may be able to see things as people enter them in. So why do we test? We test not just because we're curious or because we want to catch people in the act. We test because we are here to care for patients, and this is supposed to be a therapeutic tool. We use the test to support people in their recovery or in their treatment, not to exact punishment. Test results, whether expected or unexpected, give us a chance to explore patients' denial, their motivation for abstinence or lack thereof, and their current use patterns. Also gives us an opportunity, as many of you may have had the experience, patients sometimes come in, they say, I really want you to test me today because it's going to come back negative. And that's an opportunity for us to congratulate people for the progress that they've made, whatever that is. People come in, please test me today. I want to show you how well I'm doing. And that, as I'll talk about, is one of the core principles of motivational interviewing, to reinforce self-efficacy, to make people feel like they are in control of something that they previously didn't have control of. Obviously allows us to make initial assessments, decide if someone has an opioid use disorder, and make a plan based on what their current use pattern is, and allows us to monitor current treatment plan effectiveness. Particularly, I would highlight with regards to adherence to their prescribed medication. We want to make sure that our patients are deriving benefit from the treatments that we're prescribing, just like you would check someone's blood pressure when you put them on a blood pressure medicine. Check their A1C when you put them on a diabetes medicine. We want to check a urine to give us a sense of if patients are adherent and if they are deriving benefit from the treatment that we've planned with them. Key vocabulary from a pretty decent article in Mayo Clinic Proceedings for 2017. It's kind of like everything you need to know about urine toxicology testing. basically the analyte is what we're looking for, what drug we're testing for. You've already heard me use the word expected or unexpected. It's a way to describe whether or not the urine actually is showing things that you want or expect to see, or things that you're not expecting to see. It's kind of a nice, neutral, non-judgmental tone. It also helps you get out of the little trap of having to describe someone's urine as positive for buprenorphine and negative for other substances. They're getting prescribed buprenorphine, their urine was positive for buprenorphine as expected. Positive versus negative describes whether an analyte is detected or not. It's kind of confusing, and even though those are words that are used in normal language, it also is medical jargon, because positive in normal language means that something is good for the most part, and not everyone understands that if someone's test is positive, that can sometimes be bad. The window of detection is the expected amount of time that a given analyte will be detectable in a given matrix. It's a frequent question that comes up: how long would we expect this substance to be detectable in the urine? Matrix and matrices, I think we described that already. Clean versus dirty. We hear this all the time. It's really not terminology that we want to use, because sure, clean sounds nice, but dirty suggests that someone who's used drugs is dirty, and that stigmatizes stigmatizes people rather than supporting them and meeting them where they're at in their recovery. Also mentioning some important terms: presumptive versus definitive. So there's two basic categories of urine toxicology testing. There are presumptive tests and there are definitive tests. So presumptive tests tend to be enzyme-linked immunoassays. So those are either in solid form on a dipstick, just like a urine pregnancy test, or in liquid form, which is the typical form that's used by larger commercial labs. I think the fact that it's in liquid form allows it to be analyzed and processed through machines faster. These are typically qualitative. They give you a yes/no answer. Sometimes those answers are a little ambiguous. They give you a preliminary result, some frequently referred to as screens. They're simple to do because you just dip it. Sometimes cups have a built-in dipstick. Sometimes you have a little dipstick that you dip in. You can get a variety of dipsticks for a variety of analytes. And typically, it gives you a sense of whether someone is positive for a class or a category, because you can imagine that analytes within a given class are going to cross-react with the enzyme that has been designed for the parent compound. So morphine, I'll talk about later, morphine is the kind of prototypical opiate that's being tested for on these screening tests. Hydrocodone, structurally similar at the part that would bind to the antibody, and so will typically come up positive. The downside is that they can't give you very much information about substances within classes, so can't distinguish between hydromorphone and hydrocodone on a dipstick. They're qualitative rather than quantitative, so if you're interested in looking at trends, you can't see those. And there are more false positives and false negatives, so that's why it's a presumptive screen. If you want laboratory confirmation or laboratory-driven certainty about whether a given analyte is present in your test matrix, you want to get a definitive test. Those are typically GCMS or LCMS, so mass spec testing, looking at the molecular structure of the analytes that are detected in the urine. These are really not done in office. I don't know why this chart says that they can be done in office. They're really done as sendouts. They're more expensive, but they can give you actually a quantitative level of detection and detect a wider variety of drugs with greater certainty, higher specificity, and higher sensitivity. More expensive, slower, because you got to send them out. So The most effective, cost-effective definitive test is, so you want to type it in the comments here, what is the most effective, cost-effective way to get a definitive answer about whether a patient has used a given substance? Don't everyone type it once. Yeah, I can't even see your responses.
Are you able to see? No one's typed anything yet, just to let you know.
Okay.
I see anything.
I haven't seen anything yet. So the most cost-effective definitive test is asking the patient. So somebody comes in, maybe they've gotten a dipstick test before you even see them, and it comes up positive for cocaine and oxycodone. Rather than getting a reflex, the lab companies want you to get everything with reflex to confirmation if something comes up positive. Rather than doing that, you can just say, "Hey, did you use any cocaine? Or how much cocaine are you using?" And avoiding yes or no questions. And the person says, "I'm using about 3 times a week, not that much." So you just saved, the insurance company $65 or whatever they're going to get. They're going to get charged by the commercial lab to send for the confirmatory test. And again, the whole point of this is as a conversation starter, as a therapeutic tool. If you have to wait a week or 2 weeks or whatever till the next time you talk to the patient, then that's an opportunity missed to have a conversation about where this patient is in terms of their recovery. Truth is, not only is this a cost-effective approach, but the concordance between self-report and biochemical verification in people who are looking for drug treatment is really high. So greater than 80% across a bunch of studies. That concordance might be different, as you can imagine, in people that are not treatment seeking. People who are being seen for pain treatment in the primary care or specialty pain setting. They might have a greater incentive to prevaricate when it comes to their current drug use. But still never hurts to ask, "Hey, so tell me about what you think I would expect to see in your urine today. What have you been using lately?" The nice thing about presumptive point of care testing or screening tests that you're getting in your office is that it allows you to respond quickly to the test results. You can attach a meaningful response and deliver it as soon as possible after the patient has produced the specimen, preferably on that same day. And the point is that you're using a non-judgmental, non-confrontational, and non-stigmatizing approach to having a conversation about these test results. So as an example, I say acknowledge uncertainty. I say something like, "I got this urine from you today and it showed some things that were unexpected. What do you think I found in the urine today?" Just to make sure that, what do you think I should have expected to see on the urine? And the patient might say, "Nothing. I just should be my methadone, or just should be my buprenorphine." Or they might say, "I smoked a little weed the other day." Or they'll say, "Yeah, doc, I relapsed. I used fentanyl and cocaine." So having that initial conversation can actually start to build a therapeutic conversation even before you've even talked about what you detected in the urine that day. Maybe the urine comes out with nothing and the person has cocaine. The person says that they've been using cocaine, fentanyl, and heroin. Then actually the conversation was even more useful than the urine test. If there's some disagreement between what the patient is anticipating getting, if there's some disagreement between what the patient is anticipating their urine showing and what you detected, it's, again, the point of this is that it's a collaborative and non-confrontational approach. You say, it's funny, these tests are not perfect. Tests give us false positives and false negatives all the time. We get a routine test so we can monitor your progress in therapy and make sure that the treatment that we're offering you is working effectively. And what we found today was different than what you were expecting us to find today. So let's come up with a plan to move forward with this. And basically, this is an example of maintaining the spirit of motivational interviewing, which, as a brief review, means that you're stepping away from the expert role. You're coming alongside the patient to collaborate with them on whatever medical problem you're working on, or behavioral problem you're working on. You're expressing empathy. Hey, it must be really confusing that we're finding something different in the urine than you were expecting us to find. or that I can see, that must be upsetting, or tell me what's been going on. It seems like things have been a little bit harder than we initially talked about. Evoking or drawing out clients' ideas about change, that means like the idea that having the patient say, I'd like to make a change. I'd like to show you a urine next week that doesn't have cocaine in it. Okay, so if you can get the patient to say something like that, generally speaking, that helps them move towards that behavioral change that they're describing. Supporting self-efficacy, highlighting, as we said, hey, that's so wonderful. You have managed to achieve sobriety. You've managed to stop using whatever drug was causing a problem for this person. This is an opportunity to have a conversation of this kind. In terms of, excuse me, I'm going to cough. Rolling with resistance. Sometimes I just say the customer's always right or never disagree. I think it's a principle of sketch comedy as well as working with, when you're working with individuals with dementia. There's no point in disagreeing with. There's really not a whole lot of point in disagreeing with extending or expanding on a disagreement that you're having with a patient. Patient can, say, there's no way that there's going to be fentanyl in there. So you say, yeah, that's really strange. Sometimes our tests don't line up with the way that people are, what people are expecting it to show. You're not the first person to be surprised by to express surprise about what's in their urine. Let's make a plan for moving forward to make sure that, these urines reflect the success you've had in treatment. And so you're in that way able to push people in the direction that you want them to go without ever having to disagree with them when they're actually trying to go in the wrong direction, like maybe lying about what should be in their urine. I'm going to shift gears from motivational interviewing, and I'm going to talk about the particulars of some of the test matrices. Really choosing the test matrix is, the fundamental question is, how are you best going to answer the question that you're trying to get answered? Urine is the best established, and we'll talk about some of the things about urine testing that are helpful. But other matrices provide different levels of sensitivity and specificity over different windows of detection. For example, after heroin use, the heroin metabolite 6-monoacetylmorphine remains present in saliva longer than in urine, but morphine sticks around longer in urine. That's kind of interesting. So if you really want to detect whether someone is using heroin as opposed to getting prescribed morphine, because both of those are going to come up positive as a morphine test in the urine, you could consider getting the saliva test, preferentially using the saliva test. Obviously, generally speaking, in most cultures, producing a urine specimen usually is accompanied by some degree of privacy. So having getting a urine specimen that has not been tampered with sometimes can require getting an observed specimen as opposed to saliva, where you can observe them leaving a saliva sample. Pretty easy to do, really even in a public setting. And particular patient characteristics can sometimes drive the choice of test matrix. Obviously, if your patient is anuric, urine toxicology testing is impractical. If they have periuresis or an inability to urinate while observed, that can make it challenging. If you want to get a hair test and your patient is a few years further along in the androgenetic alopecia pathway than your presenter, then using a head hair test is not going to be a very good choice. By the way, the International Periuresis Foundation used to be located in Mount Washington. I don't know where they moved to now, but I once saw them while eating at a restaurant there. Anyone has problems with periuresis or patients want an advocate because for their periuresis, might want to reach out to International Periuresis Foundation. So as I mentioned, different test matrices have different sensitivities and specificities over different windows of detection. This talk is being recorded, and I can certainly share this chart, but it's in this Hereford article from Mayo Clinic Proceedings. Basically, this area down at the bottom shows that blood and breath testing and saliva testing has typically a shorter window of detection than urine. Sweat is not really used very often, and then hair has the longest period of detection that's available. I hear a lot of MACs participants call in and want to know whether they should be doing blood testing for their patients, because their thought is that it doesn't require private collection, and you can really make sure that you're getting at what the patient has been using. Honestly, blood testing is pretty invasive. It's painful to get phlebotomy, and it's, as you can see, the window of detection is actually shorter by and large than urine testing. So there's a couple of reasons that you would want to get urine testing, if possible, and practical in your practice. So talking about specific matrices here, urine testing, here's some of the characteristics of it. Both the parent drug and metabolites are present in urine, usually in higher concentrations than in blood. So probably part of the reason that it's detectable for longer is that our urine tends to concentrate substances that are like drugs that our body is trying to get rid of. And your kidneys typically filter both the parent drug and metabolites. Metabolites that may have passed through either the kidney or liver to be transformed into their current form. Typically takes some time between use and detection. That time, they say this says about 2 hours. Hard to know, but usually if people have used just before they came into the addiction treatment setting, that means they're probably using on other days as well. So it's hard to say, but typically it should come up positive within that same clinic session. As I mentioned earlier, there's point of care testing available, and it's reliable, although you do need to get a CLIA waiver to use it clinically, like other tests that you're doing in your office. There is always the possibility of misinterpretation, and this is something that I acknowledge, as I said, when I talk about it with patients. It's like a test that if it's positive, it has 1 line typically. If it's negative, it has 2 lines. Sometimes that second line, that bottom line, is like a little faint, and we're told to read the faint line as present. And so if the faint line is present, then that means that the person is negative for that drug. If that's somebody who's on buprenorphine who comes in and they have a faint second line, that's going to be a conversation where you're like, I'm not totally sure about this test, but it seems to indicate that you might not have been taking your buprenorphine recently. No test is perfect, so tell me what you think about that. And so patient might come back and say, yeah, I ran out a week ago because somebody stole it and I haven't been taking any buprenorphine. It's been rough. No need for a definitive test or confirmatory test. But if they say, it is too, I've too been taking my buprenorphine. Look, here are all my empty packs. And you say, okay, well, no test is perfect. Let's send it out for that definitive test. And in the meantime, we can, either give you a shorter prescription or do directly observed dosing, whatever is going to be available and possible in your treatment setting. As I kind of already mentioned, the immunoassays or presumptive tests have a risk of cross-reactivity with substances or analytes that are not of interest. You have a possibility of false positives and false negatives. The definitive tests, as with all of these things, are LCMS, GCMS, and different drugs have different cutoffs and detection windows. So the cutoffs in particular are important to know because sometimes the dipstick test will be optimized to detect drugs that are present in a level above some number, 50 nanograms per milliliter. Whereas the GCMS test, the machine has been set up to detect some different level, either lower or higher. So you can have a discordance between what test results are showing based on what that cutoff is. So it's just worth checking what that cutoff is. Usually it says it to the right of the test result. It'll say morphine, and then it'll tell you what the cutoff is. These are the approximate drug detection times in urine. Alcohol is a small molecule. It diffuses in and out of urine. So unlike a lot of other drugs, once you've metabolized away all the alcohol in your body, that alcohol is going to, the alcohol that was in the urine will also be metabolized away. One thing that's not on here is ETG and ETS. which are alcohol metabolites. Unfortunately, not terribly specific. People can come up positive for ETG and ETS, but the advantage of those are present in the urine for days. So someone who you really want to monitor their alcohol use, you can include an ETG and ETS in their urine, ethyl glucuronate and ethyl sulfate, ETG and ETS. Some of these numbers are reliable, some are not in concordance with my own clinical experience. Typically, stimulants like amphetamine, methamphetamine are present between 2 and 3 days. Although I see in my patient population here in Baltimore that people who are heavy and regular cocaine users, their cocaine tests can come back positive for much longer than that, potentially because of some difference in cutoffs between what the literature is using and what we're using in our office, potentially because of some decrease in kidney function. It's hard to know. Benzodiazepines vary widely. The short-acting benzodiazepines are metabolized quickly. Long-acting benzodiazepines like chlordiazepam epoxide, Librium, or diazepam Valium can stick around for weeks or even a month. Likewise with the barbiturates, big difference between short-acting and long-acting. Cannabis, if you are testing for cannabis and care about what the result is, it can really vary widely depending on how heavy you're using and how frequently you're using. Opiates, similarly, kind of the textbooks say about 2 to 3 days or so for limits of detection. Fentanyl is not on this. Fentanyl is also thought to have a short window of detection, but in my clinical experience, I think that of many of my colleagues, fentanyl seems to be extramedical fentanyl, the stuff that people are now obtaining as heroin, seems to actually stick around and be detectable in urine significantly longer than the textbooks would say. I don't have a great explanation for that. I don't know if it's that there are fentanyl analogs that have entered the drug supply that have a much longer half-life. Maybe the quantities that people are taking are much higher. And so even after 5 half-lives or 6 half-lives, there's still enough medication to trigger that to come in above that cutoff. But fentanyl does seem to be detectable for at least a couple of days and quite possibly longer. Methadone, here says 3 days. I actually think methadone is probably longer, especially someone who's been on chronic methadone treatment. But these are good questions to call and ask Max about, a Max consultant about, if you're having a hard time making your urine test results line up with your clinical impression or the patient's account about what's going on. Urine problems really have to do with their possibility of tampering. You're looking for the possibility that your patient has added something to their urine, drunk a ton of water before they came in. That was the sound of me tipping over my water. 1 second. Drunk a ton of water before they came into the office. Substituting someone else's urine for the urine that they were going to be asked to leave in your office. So expected characteristics is urine is supposed to kind of feel, look, smell, and act like urine. It's supposed to be warm because it just came out of somebody's body. It's supposed to be, generally speaking, as you know, urine is kind of acidic. pH needs to be in a physiologic range. It can't demonstrate that it is highly dilute or with no muscular byproducts. That would suggest dilution. And if it's out of the expected range, which it frequently is, again, you roll with resistance, because providing a substituted or adulterated urine is a manifestation of resistance to engagement in treatment. Say, gosh, something so strange happened with this urine sample. It's just not going to be good for our purposes. Why don't we get another urine? And it's actually remarkable. Sometimes people who come in who have left a cold, totally transparent urine sample, they leave another urine sample like 10 minutes later and it's dark yellow and warm. So gives you a sense that having that intervention, there's no hard feelings. People kind of don't even have to acknowledge that there was an adulterated urine. You just say, you're able to catch it at the time that the specimen is produced. You're able to make sure that people are giving you something that's going to be clinically meaningful. Saliva levels, talk about saliva as a matrix. Typically, analytes and metabolites diffuse in and out of the saliva from the plasma, so they typically correlate with plasma levels. Like blood, basically, as a result, has a shorter window of detection, easier to collect, especially if you don't have a weird bathroom with a window built into the side of it, like in many drug treatment or addiction treatment facilities. As you can imagine, if you've just smoked cocaine or chewed an oxycodone, that's going to give you an extremely high level. And if you've just smoked a bunch of reefer or taken stimulants, can cause dry mouth, which can make specimen collection complicated. Also, if you just had a turkey sandwich, that can interfere, or whatever, having food particles can sometimes interfere with the effectiveness of the oral fluid testing. Blood testing requires a phlebotomist or a nurse on site. It's obviously can be cause transmissible diseases. It's invasive and kind of unpleasant to get phlebotomized every time you see your doctor. The advantage of it really is that if the patient is unconscious, unwilling to consent, unable to consent, you can get a blood test like in an emergency department. So that's fine. Problem is that most blood testing then requires, hours to days to come back, even if you get in an emergency situation. So not totally clear how useful it is, other than as guiding future treatment. The keratin that covers our body can be thought of as a continuous collection device. Substances would diffuse into the hair follicle or the nail bed, and basically, as it pushes out, it basically sticks around. Head hair grows faster than body hair. It's exposed to more ultraviolet light, more cleaning products. So the window of detection is shorter than that of body hair. It's kind of like there's some thought that people who have darker, curlier hair might actually accumulate higher levels of drugs in their hair than people that have lighter, straight hair. So that's the potentially discriminatory part. If someone has spent a bunch of time around other people that are using drugs, you can imagine that their hair could be externally contaminated. It's expensive. Long story short, the American Society of Addiction Medicine says that hair and nail analysis shouldn't be used in addiction treatment, but your patients may ask you about it because their probation officer or CPS has asked for this to be done. Breath testing is obviously familiar to many people because of its use for testing for alcohol. Biggest problems are sample contamination, like a guy that I was taking care of for a while, Dr. Gray, who may or may not be on this call, also took care of him, who used to rinse his mouth out with beer after waking up in his abandoned house every morning, but actually wouldn't drink beer in the morning. He just wanted to get the sleep breath out of his mouth. So he'd come in and he'd blow in the breathalyzer. Initial breathalyzer would be quite high. Subsequent breathalyzers, did it 10 minutes later, his detected level would have dropped down to basically undetectable, which is not physiologically possible given the zero order metabolism of alcohol. Having autobrewery syndrome, where your GI tract is colonized with Saccharomyces cerevisiae, much less common. There's some interest in using breath testing for other substances, particularly cannabis, in states where cannabis has been there's been widespread legalization or decriminalization of cannabis, but this use is still exploratory. But it's very interesting, and that would be a really nice, non-invasive way to collect a drug sample. If we could have point of care breath testing for opioids, cannabis, opioids, fentanyl, buprenorphine, and the like. One thing is that, as I recently learned, breathalyzer testing is considered to be an aerosol generating procedure. So, in the context of COVID-19, it potentially requires some special precautions as you want to protect your staff and other patients if you're collecting breathalyzer testing. Sweat, all I can say is not really ready for prime time at this point. It's collected with an adhesive patch, require patient adherence to it. basically kind of like the equivalent of getting a hair sample, I suppose. Maybe we'll hear more about it in the future. So shifting gears to talk about kind of specific analytes, specific things that we're looking for in the blood. I put the kind of most useful presumptive analytes in the addiction treatment context here. There's something called like the SAMHSA 5, or I might be misremembering it, but there's a basic panel that is required by the Department of Transportation or something like that, which includes THC, opiates, maybe PCP. It's really not sufficient and should not be used as for anything other than occupational testing or meeting government requirements. Because in Maryland, really the extra medical opioid that you want to look for is really fentanyl, and that's not included in that test. If you're prescribing and monitoring treatment for opioid use disorder, you're really looking for buprenorphine and methadone, also not included in that federal testing. So put these up here. People noticing anything missing that they would like to see on the list of presumptive analytes? Sometimes you see propoxyphene on there, which was, I guess, popular in the 70s and 80s as a drug of abuse. Somehow it sticks around on these things. Anyways, there's sometimes tramadol you see on these, sometimes gabapentin, and again, depending on your patient population, these might be useful. But for the most part, this list is a fairly inclusive list of things that in Baltimore City and Maryland are the metabolites that we want to look for. The analytes we want to look for. Important metabolites that we should discuss are norbuprenorphine, which is the metabolic, the next step down in the metabolic breakdown pathway of buprenorphine, and is consistent with adherence. EDDP, which is usually written as methadone metabolite, which is the primary methadone metabolite, sticks around a lot longer and is more easily detectable than methadone itself. Benzoylecgonine, which is the cocaine metabolite. Some labs don't say cocaine. They say that someone's urine is positive for benzoylecgonine, and that can be a little bit confusing the first time you see it. 6-MAM, which is the specific metabolite for heroin, because heroin is also known as, the chemical name for it is diacetylmorphine. And so the diacetyl groups hanging off the top of it, the acetyl groups are like little arms. Those make the morphine molecule more lipophilic, allow for diffusion across the blood-brain barrier. But then as soon as the heroin arrives in the brain, it starts to get metabolized, and the diacetylmorphine gets one of its acetyl groups ripped off, it becomes 6-monoacetylmorphine, gets the other acetyl group ripped off, it becomes morphine. And so that's why someone who's used heroin will have a positive urine morphine or opiate test. And if you catch it in that intermediate stage with only one acetyl group ripped off, it is 6-monoacetylmorphine. Fentanyl, the primary fentanyl analyte is, or metabolite is norfentanyl. Oxymorphone and hydromorphone are metabolites, minor metabolites of oxycodone and hydrocodone. We'll talk a little bit more about that because oxymorphone is also sold as Opana. Hydromorphone is sold as Dilaudid. A couple other notes about these metabolites. Norbuprenorphine, I think I've included this later. Yes, I have included this later, so I will get into that shortly. The opiate urine drug screen is specific to morphine. You can have possible cross-reactivity with quinolones, which I haven't seen that much. Poppy seeds, which I actually have seen from time to time. Someone who enjoys their morning poppy seed bagel you can sometimes see cross-reactivity with opiates. You do need a separate screening assay for the semi-synthetic and synthetic opioids. So semi-synthetic opioids like oxycodone, synthetic opioids like fentanyl, methadone, tramadol, those are not going to tickle the enzyme-linked immunoassay test, so you need a separate screening assay for those. As a reminder, heroin, as I said, is metabolized to morphine. Codeine is also metabolized to morphine. Hydrocodone and morphine is then metabolized to hydromorphone. Hydrocodone is metabolized to hydromorphone, and in small amounts. Oxycodone metabolized to oxymorphone. This is an oversimplification because there's also noroxycodone, but point is that oxycodone is not metabolized to morphine. So if you do a urine toxicology test for opiates, your oxycodone might cross-react. It might not. Frequently, it does not. So the urine opiate test is not an appropriate monitoring test for your patients that you're prescribing oxycodone for. As I mentioned before, fentanyl seems to stick around a lot longer than the textbooks say. We occasionally see people that test positive for fentanyl and negative for norfentanyl. This is really most consistent either with very recent use or quite possibly, at least in Baltimore, or some of my patients in Baltimore, quite possible with handling fentanyl or being around fentanyl. Some people say, no, your urine was positive for fentanyl this month, but strangely enough, because you told me you hadn't been using, I sent it for confirmatory test. It came back negative for any sign that the fentanyl was actually passed through your body. And they say, oh, it's that time of month I had to make some money. Most of the time when someone is positive for fentanyl, though, it means that they've used fentanyl, especially if they're a treatment-seeking individual and they have had a problem with extramedical opioids in the past. We also occasionally see people that have only norfentanyl in their urine sample, no fentanyl. That's probably consistent with relatively distant use. They've metabolized away all of the fentanyl already. They just have a low level of norfentanyl that has stuck around. There's a strange misconception that a lot of offices don't test for fentanyl in their point of care testing because it's oftentimes not included in the ready-made panel. And people say, oh, it's really expensive to test for fentanyl. That may have been true at one point, but in my office, we were able to get a large number of fentanyl test strips, CLIA waived for like, I don't know, 15 cents a piece or 25 cents a piece. It's very, very inexpensive, and we didn't even have to buy that many of them. So really, everyone who's treating opioid use disorder right now should have an opportunity to do dipstick testing for fentanyl. Sometimes, actually, if you're treating someone for opioid use disorder, at least in the Baltimore area, like you can imagine that just testing, the point of care testing for buprenorphine and fentanyl alone gives you, 90% of the clinical information that you're going to want from your objective urine toxicology testing. Buprenorphine, although it's derived from thebaine, which is one of the natural opiates, so it's a semi-synthetic opiate. It is not detected by the opiate or oxycodone screen. Point of care urine testing, as we mentioned, may be vulnerable to tampering. Where I put that bullet there. Definitive testing gives you bup and norbup levels. And some fancy test panels will also give you naloxone levels. That's supposed to give you some insight into whether someone actually used their buprenorphine naloxone sublingually or whether they used it subungually and then just dipped their nail into their urine stream as they urinated. That doesn't have a very good therapeutic effect, but it does produce a urine specimen that is positive for buprenorphine and naloxone in a characteristic 4-to-1 ratio with no norbuprenorphine. So someone whose urine you see has a level of 200 buprenorphine, 50 of naloxone, and 0 norbuprenorphine is consistent with someone dipping their Suboxone strip into their urine sample. 174 patients, 70 patients who were prescribed Suboxone provided urine samples. And this useful chart from a 2017 paper by Hull shows that the most people have their urine will have about between 0.5, half as much norbuprenorphine, and most of them have really close to twice as much norbuprenorphine as buprenorphine in their urine sample. They're really significant outliers. You can see it's really in the direction of having more significantly more norbuprenorphine than buprenorphine in the urine. People who have this person down here, down at the less than 0.02, that would be consistent with not actually ingesting the buprenorphine, but just dipping it into the urine. I'm looking at the time, it's 12:50, so I'm gonna race through here. I put too many PowerPoint slides in my PowerPoint presentation. I've now learned this about myself. So next time I will have fewer slides, so we'll have more time for discussion. I will say that just briefly about the benzodiazepine panel, most immunoassays detect oxazepam or nordiazepam, not the glucuronide conjugates. I'll show you a little chart what that means. And actually, the relatively potent benzodiazepines that are usually prescribed in lower doses by responsible prescribers, so Klonopin and Xanax, clonazepam and alprazolam, are very potent. You're not taking that many milligrams of them, and the cutoff for those is relatively high, unfortunately. So you don't catch, frequently people who are prescribed clonazepam and alprazolam will have urine that is negative for those substances, even though they're taking them. False positives are relatively rare for benzodiazepines, even though patients frequently say, oh, it must be my Benadryl. Sertraline does seem to cause relatively consistently false positives for benzodiazepines. Again, nordiazepam, oxazepam are the metabolites of chlordiazepoxide librium, diazepam, Valium, clorazepam, which we don't prescribe very much, halazepam, which I've never even heard of, and temazepam. As you can see here, these metabolites are not these analytes are not the metabolites of alprazolam, clonazepam, or lorazepam. So if you are prescribing your patient lorazepam, but they have a negative urine toxicology for benzodiazepines, it may be that you're doing the wrong test. If you want to know what benzodiazepine your patient is taking, you really need to do a GCMS test. Amphetamines have lots of false positive results. You should detect Adderall and Vyvanse. You should have a positive result in your patients for whom you're prescribing Adderall and Vyvanse, or mixed amphetamine salts and lisdexamphetamine, which is metabolized to amphetamine after ingestion. You really should have a positive amphetamine urine toxicology test. So those of you who are prescribing amphetamines for your patients, or Adderall and Vyvanse for your patients, especially if you think there's a higher risk for a substance use disorder or concerns about adherence, I would recommend checking a urine amphetamine test. Cocaine has minimal cross-reactivity with other substances. And so if someone's urine is positive for cocaine, it's probably because they've come into contact with cocaine. Whether or not they ingested it or just handled it is going to be up to you and your patient to establish. Cannabis. If your patient sits in a small car around other people who are consuming cannabis for an extended period of time, you might be able to get them close to the cutoff for cannabis. I'm not going to spend too much time talking about cannabis because it's not terribly interesting. Because most of the time, your patients who are treatment seeking for their substance use disorders have bigger fish to fry. If your patient is really struggling with their cannabis use disorder, then that certainly could be an important part of their treatment. But most of the time, if someone is using cannabis in this day and age, they'll tell you if they're using cannabis. So we can try a little drill here. We have a few minutes left here. Are we able to unmute the few people who have stuck around here if there's still any participants?
Yep, I can unmute everybody.
Okay, maybe I can hear the cacophony. If you're not planning on participating, I guess you can remute yourself, or if we hear the sound of someone who's not interested in participating, we can mute them again. But just a little drill of some buprenorphine test results here based on what we were talking about.
For me, I would really just highlight again.
Can we just make it so people can unmute themselves if they want to participate? Maybe that would be the best way to do it.
What I'm doing is I'm just places or folks that are still on with us, where there's noise coming from their audio, then I'm just muting them.
Yeah, that works.
It would be restrictive.
So if people are interested, so if we're looking at patient A, for example, here, these are the results from a urine test. Creatinine was 101, buprenorphine was 220, Norbup was less than 5, and there's no naloxone in their test. Someone like to opine what this urine toxicology result would represent? I heard the beginning of an answer, but or maybe it was just a glitch. If you said this looks like someone who put their monoproduct, their Subutex in their urine without actually taking it, you would be right. It is real urine as evidenced by the creatinine level. There's real buprenorphine, but no metabolite and no naloxone. So that suggests this was monoproduct that had just been put into the urine. Next person, number B. Person B, creatinine 54, buprenorphine 610, Norbup 6, and a little bit of naloxone. And notice that the ratio between, I won't say anything. Ratio between buprenorphine and naloxone is of note.
One thing to point out, I noticed that some folks have been typing into the Q&A box. Please make sure that yeah, so I'm not sure if you can see that, Aaron, but just make sure that you're typing your questions and answers into the chat if you decide to use that, or just feel free to use the audio.
All right. Wonder if I can see, I wish I could see these, but I can't, unfortunately. Did people have any answers, Anna, that you want to read out here?
So Bonnie had said normal. She said for patient A, patient A, normal.
Yeah, so patient A, it is urine, but it is someone who just put some buprenorphine in the urine because there's no norbuprenorphine in their urine there. But it's a good one. Patient B, what I would point out is that the buprenorphine and the naloxone are present in approximately a 4-to-1 ratio, similar to the ratio that it's present in the actual in the pharmaceutical product Suboxone or Zubsolv. So that suggests that someone just dipped their medication into their urine. Patient D, we're looking at, has creatinine less than 5, buprenorphine 10,000. They said it looks like there's some Norbup present, but it was not quantitated, and lots of naloxone in their urine. What does that urine sample represent?
It looks like Bonnie said patient D added Suboxone.
Yes, patient D added some Suboxone to their urine, and maybe it wasn't even urine because it's not urine that came out of a human being, because no human being can produce urine that is that dilute. Looking down, we can do one more down here. How about patient H? Creatinine 308, buprenorphine 1200, norbuprenorphine 1000. The ratio is 0.833, and there's very little naloxone in their urine. I'm counting on Bonnie for this answer.
Pressure's on.
So that urine has plenty of norbuprenorphine in it. It's about 1-to-1, 0.833 ratio. That goes into the expected range of normal. So that's someone who probably took their medication appropriately.
You said the bup is too high.
The bup, I actually disagree with that. There's some people have an idea that there's going to be really an upper limit of normal for buprenorphine in the urine. But the truth is, you have to normalize the buprenorphine with the creatinine. So this is very concentrated urine. The creatinine, remember the lower limit of normal for creatinine in urine is about 30. And so this is someone who has fairly concentrated urine. And so when you're looking at analyte quantitative analyte levels in the urine, you really want to creatinine normalize them to account for how concentrated a urine is. But it can be challenging. I'm glad that brought up this point. It can be challenging because oftentimes labs will tell you that the upper limit of normal for buprenorphine is like 200 and the upper limit of normal for norbuprenorphine is 400 without actually accounting for creatinine normalization. And so sometimes I kind of want to know what it was, but I think that would require probably an extra dilution step in the lab, and that probably adds some cost on their end. But yeah, I'm less worried about high levels of buprenorphine than I am about absent norbuprenorphine.
Bonnie mentioned that she read a study about the upper limit, just as you stated.
Ooh, I would love to see that study. If Bonnie is willing to share that, I think you probably have Anna or Tracy's email address, or hopefully I put my email address at the end. I would be happy to circle back about that, and I'm always excited to learn. But certainly patient F, for example, that makes me feel like things are not going well. This person, oh, my slide got messed up, but those last I think H and G and H are judged to be. Oh yeah, this G and H were judged to be authentic. Patients A through F were judged to be adulterated in this chart here. So it's 1 o'clock. We should wrap up here, but and now I've learned again that that I should be more judicious with the number of slides I provide. But just to say that in the context of COVID, we should not be having as much in-person contact for our patients' sake and for our staffers' sake and for our own sake. So it's reasonable to put a pause on urine toxicology testing, or certainly significantly decrease the frequency at which we're requesting urine samples, and we're requiring patients come in, and because we really want to minimize our in-person interactions for ourselves, for our patients, for our communities at large. It's probably worth having kind of some more ongoing discussions about how to treat patients for opioid use disorder in the context of COVID-19. These pandemics that are disproportionately affecting minority populations, and it's really important that we do our part also to support people living with opioid use disorder, not expose them to greater risk of COVID-19 than people that have other chronic medical conditions. ASAM says continue testing only in the most pressing of cases. So just to wrap up, toxicology testing is a therapeutic intervention. We want to remember our language and our principles of motivational interviewing. Really, urine and saliva are the best. Urine number 1, saliva number 2. There's a limited role for breath and blood testing. Be even more parsimonious with your testing frequency and the kinds of testing you're doing now during COVID-19 than ever. And the point of this is that we're trying to get people to engage and adhere with their treatment. Whether or not there are blips, slips, relapses is actually less important overall than whether this person continues to be engaged with a healthcare provider that cares about them, and that's treating them with evidence-based interventions, including medications for opioid use disorder. Here is our contact information. Bonnie, if you could share that information about upper limits of normal in urine, we would be thrilled to see it, and we can add it potentially with some editorializing to our resources, and certainly have to share with other people. And if any of the resources that I shared today would be useful for any of the attendees in their practice, please let us know, and we're happy to share. Thank you for joining us.
One more thing before we close out.
Yes.
Folks are eligible to receive CME credit and CEU credit, or CEU credit for this webinar. But in order to do that, you'll need to complete the evaluation. Once you exit or leave the webinar, a pop-up window or your browser will direct you to the survey. If for some reason there's any issue with that, we'll have a link that we will send along with the recording and the slides from today's webinar, which will go out either tomorrow or Friday. And we'll try to include that article, and like I said, the slides with that. And then one quick plug, next Tuesday, June 9th, we have a webinar with our newest MAX consultant. She's our pain management specialist, Dr. Sarah Merritt. Will be presenting on opioid prescribing in primary care clinics. So join us at 12 p.m. for that. You can register on our website, which is listed on this slide.
Thank you, Anna, and thank you to all of those who attended and stuck around. And see you next time. Thanks very much.